thank you so much for having me today. I'm extraordinarily excited to have the opportunity to share and hear from everyone who's participating. So let me get this presentation up and we will share that, put it in presenter mode. All right. So I'm incredibly passionate about the opportunity to be able to partner with individuals who have narcolepsy and really augment what their experience is. I'm incredibly frustrated when I hear the challenges that many people may go through of feeling as though that they're being defined by the diagnosis or by the symptoms that they're experiencing, and losing the fact that there's an individual at the center of all of this. And many times there's also family members who are also being affected by the symptoms that the person is experiencing. So we are going to talk today about how do you engage your provider? How do you have a conversation with your provider? But how do you do so that the result of that conversation is ending up having meaningful outcomes for you specifically? So the title of this presentation is You Are More Than the Sum of Your Symptoms. And that really is so that we can set up the foundation of how an individual with narcolepsy can lead discussions and lead the care that they want. So I think it's important to further emphasize this foundation by giving you some statements. Statement number one, you are not the sleepy patient. You're not the hypersomnia patient. In fact, you are not the narcoleptic patient. You are not the difficult patient, and you are not the crazy patient. These are statements that I unfortunately have heard from both sides. I've heard it from the provider side of, I'm going to go see the narcoleptic patient. I'm going to go see the hypersomnia patient. It's another sleepy patient. I've also heard it from the patient side, describing that they are a narcoleptic. This is a chance for me to encourage individuals to recognize that you are that individual first, and you are in a journey with a diagnosis of narcolepsy. Refuse to be defined by your condition, but rather define yourself by what it is that you want to be. So we're going to go over a couple of things today. We're going to start with what is narcolepsy. And although many of you on here may feel very well equipped to be able to say, I know exactly what narcolepsy is, I think when we're talking about the journey with narcolepsy and what you want to get out of the interactions with your provider, it's important for us to lay that foundation of what are the things to expect with narcolepsy? What are those pentad symptoms? But in addition to that, what are other things that commonly come along with having the condition of narcolepsy? When you don't know, you're not going to know to advocate for yourself. You're going to hear me reference this idea of a journey multiple times throughout this presentation. I think this is one of the most important things to think about when dealing with a chronic condition, is recognizing that an individual isn't just discrete time points when you're interacting with your physician. There is a continuum of time points that make up the outcomes and the desires that an individual wants and is experiencing. Those time points are going to be highlighted of this journey and really be able to help in focusing on what does success look like? What does great look like? We're then going to define normal, because very frequently the response I hear is, I just want to be normal. I want to be like everyone else. And it's important for us to define and understand, what does normal look like? And then finally, we're going to go over some discrete strategies of how to best engage your provider, especially when you may be meeting comments from the treating physician that you're not maybe agreeing with. So first, what is narcolepsy? I borrowed this slide from Wake Up Narcolepsy's website, which I'm sure you all are aware is chock full of incredible resources and educational materials. So narcolepsy is a lifelong neurologic sleep disorder characterized by the brain's inability to regulate sleep-wake cycles. This instability really is going to be what materializes a lot of those pentad symptoms that we're going to describe. When we're looking at the classic pentad symptoms, which many of you are likely very familiar with, we know that excessive daytime sleepiness is the most sensitive symptom of narcolepsy, meaning 100% of people who have narcolepsy have excessive daytime sleepiness. It's important to also recognize, however, when we're talking about excessive daytime sleepiness, it's not a one-size-fits-all and that it looks the same in everyone. And so being able to also understand how your excessive daytime sleepiness manifests is an important description. That same instability that we were describing of causing the sleepiness to intrude during the day also is causing a very common problem of disturbed nocturnal sleep, where wakefulness is intruding into the night. There's a common stigma and misperception that you have narcolepsy, you must sleep great. But the reality is that many individuals with narcolepsy have significant complaints of how horrific and disturbed their nighttime sleep is. Other features that can be present include things like sleep paralysis, where a person may temporarily feel frozen or stuck, paralyzed as they're waking up or falling asleep. Sleep-related hallucinations. Very commonly, physicians will describe this as purely being a visual phenomena. However, in speaking with many individuals who have narcolepsy, it very frequently may be visual, but there also may be auditory or tactile hallucinations as well. Such examples of, I think I'm hearing my name called, or feet in the hallway. It makes me get out of bed and look, and I feel uncomfortable being able to sleep at night, feeling as though I'm having pressure on me or being poked or touched. And then finally, cataplexy. Cataplexy, by definition, is transient episodes of loss of tone. So very frequently described as these brief periods of weakness. There can be generalized or partial cataplexies. Individuals with generalized cataplexy will have complete collapse to ground, where partial cataplexy is only going to involve certain segments of the body, head drops, things dropping out of my hands, knee buckling. However, I would challenge that definition that we very frequently reference and incorporate the descriptions that have been known since at least the early 2000s, where Dr. Plazzi out of Italy published a beautiful publication describing the active motor phenomena that can also occur in children in new onset narcolepsy, recognizing that things like tongue thrusting, eyebrow raising, and even abnormal movements can also potentially be cataplexy. Understanding that there is this wider breadth of cataplexy becomes really important, because when a doctor is asking about whether or not you have cataplexy and it's well controlled, if you don't necessarily understand what your symptoms might look like, you may not know to report them or what they may be influencing in terms of your day. Now, these classic pentasa symptoms are ones that most people are going to be very familiar with, and you're going to be asked about them. However, we need to also recognize that individuals with narcolepsy may be at risk for other things, such as autonomic changes. Many times individuals may have things like POTS, postural or orthostatic tachycardia syndrome, where your heart rate and your blood pressure may not be responding the way it normally should. There can also be skin color changes or temperature changes that individuals with narcolepsy may experience. Very commonly, brain fog and cognitive challenges that exist irrespective of the excessive daytime sleepiness that's present. So I get your sleepiness under control, but you still have the difficulty of saying, I can't concentrate, I can't focus, I can't process exactly what you're saying. Automatic behaviors. So looking like you're on autopilot, doing things that you're not recalling. Very frequently, it's feeling as though I'm not dozing during the day, but the challenge is that I still can't make out what my notes are from school, or the test that I was taking. I got failed it because of the fact that I went into automatic behavior and didn't actually answer the questions that I knew the answers to. There could be mood changes, weight gain, and other sleep disorders. This becomes important when we're trying to improve the outcomes related to narcolepsy. If there's the lack of awareness that there may be other sleep disorders that may be contributing to why the symptom control isn't what we would like it to be. So after setting the foundation of these are some of the factors that may exist in an individual who has narcolepsy, how do we describe this over a course of time? So I think it's really important to talk about a journey. And so in the next slide, I'm going to share a video with you. And in full disclosure, this is an individual who I take care of. And it is a presentation that my healthcare system had created about his journey. The reason I want to share this is not for self-endorsement. It really is because I think when describing a journey, giving an illustration of what someone else has experienced allows for a lot of people to better resonate as to what the journey is that you've been on. The other part about this illustration is that it not only will describe the journey for Max, but also for his family and how it impacted so broadly, and how being able to partner and be able to express what your outcomes that you want and are a priority to you can really be transformational in terms of the care you receive. So I'm going to start this presentation and I'm going to skip a portion of it so that this way you're able to see more of a focus on the journey.
Past 3 years in high school, I wasn't able to wrestle. So all I really got is just upcoming season to show what I can do. It's been a process, but I think I'm at the point where I can actually go out and compete. My first symptoms kind of came when I was about 9 years old. I had really bad nightmares. Had a lot of sleep paralysis. Didn't tell anybody about it because I thought I was like kind of going crazy, not gonna lie. And it was very overwhelming.
When we pulled up into the driveway, he was slumped over in the front seat and he was out. And I thought he was joking because I didn't think he wanted to take groceries in the car. And I'm like, Max, come on, get up, haha, funny. And he was out, like completely out. The only thing holding him up was his seatbelt. And I started shaking him and I said, Max. And he got up and he's like, Mom, I just passed out.
I was just scared and frustrated at the same time because I didn't know what was happening. I didn't know what was wrong.
He was in school and then he passed out and Dave called me and he said, he's out again. And then I said, I'm leaving work now and I'm taking him. Geisinger, they were amazing because he took him in right away.
Yep.
And I remember, the resident there was great. The doctors were immediate. And I'll never forget this. He said, you're not leaving until we know what's wrong. For that, I'm so grateful.
Max has a condition called narcolepsy. Narcolepsy is a chronic neurologic disorder.
Once I found out about narcolepsy, I was like, what is it? And then Dad told me about it. I was astonished. And I said, when did this start? And Dad said, 9 years old. And I was like, oh my God. All those times he's been treating me right. I had no idea that he's been going through it. It was shocking.
I was relieved and I was like, all right, now I know what I'm dealing with.
She said to Max, she said, you are going to have a normal life. You will be fine. And she said, I promise you.
Dr. Morse knew stuff we didn't know, and she looked right at Max and goes, everything, like that, and like, everything. And Max looked at her and goes, you mean everything? She goes, the stuff your parents don't know about, you'll get through it. And that's the first time our son showed emotion in 6 years. And that was my moment when I thought everything was gonna change.
If I didn't have her in my corner, I would definitely not be here today. She was a gift. She helped me have the ability to wrestle again, the ability to do what I want to do. So she got me diagnosed and she got me on some good medication.
One thing he said was, it's just nice to know I'm not crazy.
Yeah, because you're a kid, you're dealing with this, and you think there's something wrong with you. And then all those things went away as the medicine went in. It's like, I'm not crazy.
His story is one that is meaningful and moving, not only because of the delays that they experienced and all of that arduous journey that they already had, but really because we're experiencing that light at the end of the tunnel that should be shouted from the rooftops. Narcolepsy is not a condition that at this point there's a cure for. However, I think when we reflect on a story like Max's, he is someone who can say he conquers narcolepsy. Why? Because he does it every single day. He beats narcolepsy every day. He gets out of bed, he takes on the day, and he wins. So I think you can say that you can beat it or you can conquer it because it's a mindset. So again, in full disclosure, this was by no means an intention of self-promotion, but I do think that after listening to this, I would love to know if others find that they can resonate with that. So not only do you see how along this journey, it impacted him from the excessive daytime sleepiness to inability to participate in wrestling for 3 years. His father was a nationally recognized wrestler. Wrestling is a very, very important part of that family culture. the inability to do something that he loved and competed well at, the fact that there was the development of significant self-criticism and feeling as though that they were crazy, they were lost. The family's responses of, in 6 years, it was the first time that I saw emotion. So when I look at Max's journey, and I'm saying the outcome of just looking at excessive daytime sleepiness or cataplexy as a goal of treatment, that's not the win. The win is shaping the mindset where I can still do what I want to do and being able to create a journey that is specific to the desires that he has. So when we look at the journey, I think it's important for us to evaluate what are these points along the journey. So very frequently, that journey gets shaped like this. We think of the period of time when narcolepsy was not a part of my life. There then is a period where there was symptom onset. You frequently are going to seek out care. And for many patients who have narcolepsy, that journey includes seeing 3 to 5 specialists and potentially getting up to 3 to 5 missed diagnoses. You finally become diagnosed, and then there's the establishment of treatment. So very frequently, we think about the journey in this capacity. However, this is only part of the story of the journey. It's important to recognize that that journey includes all of these other critical components in terms of developmental outcomes. We recognize that if it's an individual who developed narcolepsy at a young age, like Max, that there's implications in how you're making friends, school performance, extracurricular involvement. And so saying I improve excessive daytime sleepiness alone is not an adequate measure of success in partnering with my patient. What the accurate measure would be is that they're able to go back to wrestling. They're able to get back to getting attendance in school and getting good grades. And so I encourage individuals who are on their journey with narcolepsy to identify where in this journey you are, and then what are the outcomes related to things that matter, so that we can utilize those to drive the conversation and drive the outcomes that you want. So defining normal. One of the things that very frequently individuals with narcolepsy who I take care of or partner with in care will describe to me, I just want to be normal. The challenge with that statement is that normal for me is not the same as normal for you. And normal for me, even at the age of 5 versus the age of 10 versus 15 versus now almost 40, has evolved very much. And the normal at one of those other time points wouldn't be acceptable at another time point. So instead of us saying that we want to be normal or our goal is normal, which doesn't seem like a tangible or measurable outcome, let's start with a 2-step process. Step 1, what can't you do because of narcolepsy? It's not asking you, what can't you do because of your sleepiness? What can't you do because of your cataplexy? How does the experience of having narcolepsy impair you on a day-to-day basis? Why? Well, because these are some real-world responses that I've heard. I can't have emotional bandwidth. I can't show up emotionally for the people I love. I can't drive. I can't pursue the career I wanted. I can't trust myself to hold my sister's new baby. I feel like I'm a burden to my family. I can't provide for my family. I can't afford the housing that I think my family deserves. I can't stay awake. Excessive daytime sleepiness wins every round. I can't sleep all night. I can't help my kids with my homework. I can't sit in a boring movie or really any movie. Can't do skydiving. Cataplexy will definitely ruin that event. Snakes and spiders or anything scary. Hiking or swimming alone. Nightclubs, pubs, other things that my peers are able to do at night. I can't take notes in class or do well on tests. I can't participate in sports, or my participation has worsened in regards to what my capabilities are. I can't have emotional conversations, so therefore I avoid them. The reason I think it's important to look at these real-world responses and understand what narcolepsy is limiting in your life is because that helps create the goals that we want to experience. Step 2 is then saying, how do we create these tangible, measurable goals? After defining your limitations, define what great looks like. What would a great transition from what this limitation is look like in my life? How do I measure progress to there? Try to avoid comparisons to other people. Compare yourself to yourself, your future you and your past you. And then map that out, ideally with your provider, of what does progress look like? What are the strategies that we're going to utilize to monitor this progress? And please stop them if they tell you it's an Epworth Sleepiness Scale. Don't accept less. Continue to strive towards that goal. So how do you engage your provider? What are things that you're able to do to be able to transition these conversations? So one of the biggest frustrations is the cynicism around Googling symptoms. So very frequently patients will say, I know I shouldn't do this, but I Googled this. And when your provider tells you not to Google, I would encourage you to respectfully respond with, could you please provide suggestions then for resources that I can use to better educate myself? Are there support groups you recommend? Are there online resources, paper resources? The reality is that this creates the foundation of how you can drive the directionality of the care that you want and the outcomes that mean the most to you, not artificially predetermined ones that may have been developed by either physicians or insurance companies to say that you're better because we see a validated scale get better. You're better when you describe to me that you're able to do things that you were limited in being able to do previously. And so making sure that patients who are experiencing these diseases are well educated on the symptoms, the options in treatment, and the social support that is available is a foundational step to being able to be more in control of the direction you want. Let's start you on X treatment. What are things that you can do to engage your provider to ensure that you're making the right decision in regards to treatment? So question number 1, what symptoms will this actually treat? I have symptoms of maybe Depend symptoms, but maybe there's other things that you're identifying. How will we monitor improvement? When will we monitor improvement? What can I do to better keep track of the symptoms so that we can both be assured that I'm on the right strategy? When will I start to see improvement? We're starting this drug today. When will I start to see that I will have improvement in the symptoms that we're trying to get better? Will this impact any of my other conditions that I have, whether they're mental health or physical health conditions? And if I have side effects, is there any risk to stopping abruptly? I think these are important because although very frequently physicians and other clinicians are very interested in improving the outcomes of patients, typically the conversation around treatment isn't incorporating all of these questions to be answered. And so I do encourage individuals to ask these questions, have them as your list of things that you want to discuss with your provider. It looks like you're doing better. Your Epworth Sleepiness Score is better. So very frequently, I think people hear this. My response is always telling other clinicians that I have yet to have a patient ever come into my office and tell me that they're there to see me because their Epworth is a 17. It typically is driven by what is the disability and experiences that the individual is having, and that's why they're there. And therefore, we should measure the success of our interventions based on those same tangibles. So ways you can respond would be, yes, in fact, I'm now able to. So giving that reminder of, I agree that my Epworth is better, but the way I view my improvement is that I now am able to help my kids with their homework and I'm able to cook dinner. I now am attending school. I have no absences and I'm back on the honor roll. I now am having date night again with my husband because we haven't done that in years because I'm usually asleep or I just don't have the energy to do so. Sorta. I'm less sleepy, but now have recognized that cataplexy is a thing that I'm experiencing. I just always thought it was sleepiness. And that's why I felt clumsy. But I actually do recognize now that I have cataplexy. Or perhaps there's another symptom that becomes more predominant in your view. No, I'm less likely to doze. I'm not falling asleep inappropriately or dozing inappropriately, but the quality of wakefulness is still not good. I'm awake, my eyes are open, but I still am having the brain fog, the cognitive clouding, the emotional lability. These become really important to be able to better direct. Some of the experiences that I've had in engaging with people who I take care of is that there sometimes is a reticence of disagreeing with what the Epworth was. There's a hesitation of saying that I want better because they feel guilty of that. You're trying, but I would still want better. So I encourage you in along your journey to always frame where you're at in regards to the goals that you have for yourself and be able to kind of understand that these sometimes aren't yes and no questions, and that there are these ongoing opportunities to remind your provider of what great looks like for you. So another statement that I sometimes will experience is one like this: if you're going to get pregnant, we need to stop your medications. Responses I would encourage would to ask why. What are my options? Does these options change over the time of pregnancy, the preconception, the trimesters, the post-delivery? What are the behavioral management strategies that I maybe can incorporate if I'm going to need to come off medications? And what are other resources that are available for me and my partner? Wake Up Narcolepsy is an exquisite example of resources that are available in the family planning dynamic. Focus not only on the woman who's going to become pregnant, but the whole family dynamic, how the partner can support, or if it's the man who has narcolepsy and how they're able to engage in parenthood. So these are things that I think are really important, and depending on where you are in your journey may be relevant or may not be relevant. And so again, reshifting the idea of what are the outcomes that I'm looking for and how do I incorporate it into where I am now and what it is that would be my optimal outcome. The other piece that I think very frequently gets overlooked is when we're having a physician-patient interaction. It very commonly becomes focused on the medical treatments that are pharmaceuticals, and very frequently gets overlooked in regards to what are the other things that we can do to optimize symptoms. First and foremost, ongoing education is always going to allow for a better journey. Incorporating things like social support, knowing that you're not alone, feeling like you're not crazy, making sure that you're able to capitalize on the experiences of other individuals who are going through a similar journey of yours, so you don't feel like you have to reinvent the wheel. Augmenting coping strategies, lifestyle optimization, and behavioral strategies. There's now cognitive behavioral therapy for hypersomnolence disorders. And this very much is focusing on a lot of these different strategies. The final piece is also recognizing that narcolepsy is a condition that is protected by the American with Disabilities Act, and therefore a lot of times is going to allow for school and workplace accommodations, helping to augment the likelihood of success in all these different venues. So in conclusion, one of the things that I would like to leave people with is that you are not defined by narcolepsy. Narcolepsy is a condition that is going to be a part of your journey, and it's going to shape your journey. However, you should allow for the designation of what is it that looks great to you. Education, empowerment, and active involvement is key to optimal outcomes. In order for you to get the outcomes that you want, we do need you to be in the driver's seat. You need to direct your provider as to what it is that you see great looking like. Define your goals and communicate them to your provider, not only once, but continuously, making sure that you're having the ability to monitor progress and be able to shape it. Your provider is your partner, not your parent. Being able to encourage that relationship is really critical. And then finally, don't accept less. If you identify that you're in a patient-provider relationship that is not encouraging this dynamic, there's always the option of seeking out another opinion that is going to encourage your active role in the care that you think will be optimal for you. Thank you.
Dr. Morse, thank you. What an inspirational presentation. And I love the whole shaping the mindset. I think that's so important. So We do have a few questions. Pamela Cohen said the video was incredibly helpful. She has said her entire life that all I want to know is I'm not insane. So thank you. I thought the video was amazing as well. Somebody mentioned how many providers or how many providers will recommend support groups? Not a lot to his experience.
Yeah, I agree with that. I think that one of the biggest challenges is that I think physicians aren't well educated on utilizing this as a resource that is extremely advantageous for individuals going through this journey. So I think that support groups have so much value because of exactly what others are echoing of that. I don't want to feel alone. I don't want to feel like I'm insane or crazy. And the reality is that it almost has to become a part of medical training now for physicians to recognize that, number one, you're not going to have all the answers. Number two, you likely don't know better than what the patients who are experiencing the disease process are. And I think it's really important for that to become more and more socialized. The mental health space has done this phenomenally. And in fact, what has driven the recommendations for support groups and peer support has actually been structured research around how peer support has transformed outcomes and adherence to therapies and being able to improve what we're seeing in terms of the mental health conditions. And so I think we can borrow from that and eventually start to move towards research models that actually demonstrate where that value is. So incorporating it into those evidence-based medicine recommendations that allow for us to have that as part and parcel of management.
Thank you. Matthew says, greatly appreciate your support for the community. Every time I hear you present, I am reminded of how empowering a doctor-patient relationship can be. Always get teary-eyed too. Your emphasis on social support is essential to our health. What are your thoughts about organizing a position statement or guidelines for prescribing, quote, social support for patients and caregivers of those with central disorders of hypersomnolence?
I love it. That actually, so one of the things that I love about where I work is that we very frequently are always trying to be innovative of identifying new ways to get the behaviors and the things that are going to make the most difference to individuals. So this reminds me a lot of, in our pediatric practices, we actually have something called prescription to play, where literally the doctor writes a prescription for a child to have X number of minutes per day of playtime. So getting them off the electronics, getting them moving, trying to help in fighting that obesity epidemic. Why do I make that analogy? Because that same concept should be encouraged here. Why? Because by saying, I view this as so important as a part of your care package that I actually am prescribing it to you, further validates that to the individual receiving it, that this is a critical component of optimizing my care experience. It's a critical component of that journey. And so I agree. I think that this is something. I think one of the things, again, that's going to further bolster this, however, is if there is some sort of standardized evaluation of the impacts, creating those outcome measures of how is the care journey and how are the outcomes that patients value changed when social support is there versus it not being there. I'll tell you, I've tried to partner in the past. Julie Flygar has done an incredible job of trying to get this off the ground. And one of the criticisms that we kept getting in regards to funding for these efforts was that there's no prior research or literature that demonstrates that social support makes a difference for narcolepsy specifically, even though we're able to demonstrate that in general, there's other disease states that make that difference. And so the absence of evidence isn't the evidence of absence. And I would say that we do need to, again, further bolster an opportunity to create a position statement or guideline by being able to also demonstrate where those values are, so that there can be continued investment in growing those types of supports.
Thank you, Dr. Morse. Christina states, thank you so much for this articulate presentation. I would love this to be presented at every medical school in the nation. Please consider making a YouTube of this entire presentation. Thank you, Dr. Morse. You are a genius in your profession, and I echo that. Are you able to share the video with us through chat?
Yes,
Okay.
yes.
And also we will be recording this and putting this on our website, which will then go on YouTube. Are you able to, I don't see any other questions there, so please send them in if you have, audience. Are you able to mention possibly how kids can become their own advocate and talk to their providers? How does that kind of work?
So I think when you're talking about children with narcolepsy, it is very important to engage them from an early age of understanding their symptoms, being able to express how those symptoms are affecting them, being able to express what they want to be able to do is so pivotal. So very frequently when we're talking about engaging a child in their treatment, it becomes hyper focused around how do we get them to take their medication, right? How are they taking their medication on their own? How are they keeping track of it and trying and always thinking about that transition of care? But I think from an early age, there's an opportunity to be able to empower a child in being able to verbalize their experience and also be able to understand where they're getting better or where they're maybe seeing a backslide. Some of the things that I've seen is that I may have a child who's 10, 11, 12 years old, and the parent drives a lot of the conversation of telling me, this is how I'm seeing symptoms getting better, or what they're able to do, not able to do. I'm worried about X, Y, or Z. And what I have found is when I ask the child, are you sharing that same experience that mom or dad is telling me? Very frequently, there's a disconnect there. And so sometimes the child is afraid to kind of speak up because the dynamic typically is that the parent is the one who knows what's right to say, and they tell me how I should manage my condition. So in those dynamics, I think it is really important for the child to start to learn the language of what they're experiencing. And so I generally try to use this opportunity to utilize not only what is like medically appropriate language, but also translate it into something that is more socially appropriate that they can understand. This evolves over time because, again, when thinking about that journey, the goals and what is important changes over time. So the parent still may be very hyperfixated on the child doing well in school, but perhaps the thing that becomes more of a priority is like, I'm doing well in school, but I still don't have the energy to do the social activities that are important to me. And that is, again, two different goals, two different outcome measures that we want to continue to make sure we're honoring. So I do think that from a very early age, helping the child be able to understand how to express what their symptoms are, what the impact of their symptoms are, as well as what their experience is with the treatments that they're involved in. I also very frequently want the child to be an active member in the discussion around which treatments do you think are most realistic? Which treatments do you think you're going to be able to stick to or tolerate, or whatever may be a limiting factor?
Great, thank you. Just somebody's asking if the script of the presentation will be provided, and we'll have the recording, and I think that you can just do the audio script through YouTube. So I think those are all of the questions we have today. I do
love to pose a question to the audience.
Sure.
I would love to know. So I picked some of the more common things that I've heard patients describe of challenges in communicating with their provider. I would love to know from the audience, what are some of the things that you've experienced on the patient side that there was a clear disconnect between what your provider was saying and what you were trying to get at? And the reason I asked that question is because I want to broaden my scope of understanding, how can we continue to evolve this care paradigm? How can we make sure that when I'm speaking to other physicians, that I'm reminding them that these are struggles that individuals with narcolepsy are experiencing, and be able to help in continuing to kind of coach around this idea of what is better language we should be utilizing, what are better outcomes that we should be looking at, and a reminder of that this does not stop at the clinical visits in regards to the things that are important. This also needs to be incorporated in future pharmaceutical design of saying you improve excessive daytime sleepiness, you improve cataplexy, but actually have you improved quality of life? Have you actually improved any of these outcome metrics that the individuals with narcolepsy are clearly screaming from the rooftops that this is an important outcome change? So I would love to hear from anyone in the audience of challenges that you've experienced and or continuing to experience, and what we might be able to do better to kind of change those.
Or just change the chat so people can put their answer right in the chat button.
So one said, I was sent to a psychiatrist and misdiagnosed as bipolar and prescribed lithium, which created later delays in proper diagnosis. This is such a very frustrating part of that journey, is the missed diagnoses that very frequently add again onto that burden of disease. And so I think one of the things as a field, we really need to start making sure we're asking the right questions. One of the biggest challenges is that many psychiatric diagnoses do have a sleep component to it. And so I think there needs to be ongoing efforts from the sleep community of partnering with psychiatry and neurology, where a lot of times this kind of misdiagnosis is occurring. And I apologize that you experienced that type of frustration. Another is, how can you put the priority of the parent thinking about the child's future in the right proportion towards the child's wish to have a childhood? That is such a great question, right? And so this is where we need to kind of, again, think about the journey, not these discrete time points, and be able to evolve. How are we prioritizing that I want my child to go to college, I want them to be a successful adult, I want them to be able to get married, I want them to be able to have kids. Those are all very important. I think, again, when you're taking care of a child who has narcolepsy, understanding where they view a value to their intervention is important for them to also establish buy-in and interest of these very far things that at this point have no relevance to them. They can't conceptualize that. And that's a child with or without a medical condition. So very frequently, it's kind of putting in a treatment paradigm that is allowing the parent and the child to evaluate the ongoing progress and to look at, are we actually creating the support that is going to allow them to be successful later on, but then are we also achieving the things that are most important right now? So I don't think that it's necessarily prioritizing one over the other, but rather giving that roadmap of, this is how we get there. This is how we're monitoring progress. This is how we're going to make sure you have the right behavioral interventions and strategies to not only be successful now, but to build on that foundation so that later the outcomes that are of priority to parent is going to be more likely. Then the sleep doctor, go ahead.
Oh, I was just going to read that for you, but
Sure,
this
go
is the
ahead.
same woman. Then the sleep doctor that she had would not prescribe Xyrem when modafinil was no longer working, and called her a drug addict. And when she insisted on it, in the end, she had to switch doctors, which is a privilege that not everybody has.
Yeah, and that this is a very challenging dynamic, because when you're taking care of individuals with central disorders of hypersomnolence, all the drugs we use are pretty much controlled substances, with rare exceptions. And very frequently, there is this stigma around prescribing controlled substances. And unfortunately, this is why I do encourage people to really qualify and quantify how the burden is being experienced for their personal journey. Because when you have individuals, physicians, and insurances who are going to measure how well you're managed by artificial measures, again, validated scales, but not representative of what your real life experience is. It's very easy for them to make these knee-jerk reactions that are insulting. And they also are contributing to those delays in care. It also is contributing to poor communication between the patient and the provider. And it's also contributing to increased burden and many times the development of secondary comorbidity, such as true depression or anxiety or obsessive compulsive disorder, because of compensatory mechanisms to the experience they're having.
Next, as a parent of a recently diagnosed young adult, the largest disconnect that he is seeing is the approval of physician recommended medications or treatment regimen Insurance approval should not drive my child's treatment due to test scores.
I agree with you. I think this is a very interesting dynamic. So right now, I actually am I'm in Austin, Texas. It's a beautiful part of the country. I've never been here, but I'm at a meeting where it is an intersection between payers, providers, and innovators. And that has been a conversation I've had with a lot of the payers here, so major payers from across the country, and describing that the current algorithms that are being utilized are not in favor of the patient. And one of the biggest challenges is that healthcare is trying to go in the right direction of, instead of this, what we call a fee-for-service model, where it's all transactional, that it's being moved to value-based care. So are we getting the right outcomes for our patients? The challenge is that on the clinical side, we're going to be held to value-based care, but the insurances aren't anteing up to say, we also are invested in this outcome. They're continuing to tie hands of not allowing us to be able to prescribe the medications that are most optimal for the patient who's in front of us. Recognizing that there's no chronic disease where a one-size-fits-all solution exists, and being able to have the ability to respond to what the patient's needs are with the right medication at the right time is very critical to reducing the burden of disease that person is experiencing.
Excellent, thank you. This next person, very, very critical to my entire care for most of my doctors. They assume I want to get onto strong medications such as Xyrem, which I don't, and that colors how they hear absolutely everything I say. I just had an MSLT and felt judged as trying to get onto hard drugs, quote, rather than evaluated for what they could offer to help me. This talk was gold to me. Thank you.
Thank you. And I think what's very important is, very frequently when I discuss with patients, what are the treatment options that are available, I try to avoid using terms like this is a stronger drug, or that this is some sort of characterization of a drug that may be misleading. And the reason I state that is because the drug repertoires that we have available all have roles. They all have a role, and I use all of them depending on what the patient's needs are. And so again, making sure that we're personalizing the care to what the individual wants is really quite important.
Thank you. Somebody said, thank you for all great answers. Our community would be doing a lot better with 100 copies of you. I agree.
Thank you.
I've had providers ignore or downplay side effects of certain medications because other symptoms had improved rather than discussing other medication options. I've also had providers be more distracted by other health conditions and tell me my symptoms were actually coming from other medications. I've had to stay with less than great providers due to geographical limitations and very large wait lines, or had to go without medication for periods of time.
Oh, I'm so sorry for that experience. And you're right. And this is part of the reason why there does need to be these types of communications, and why I also wanted to prioritize the types of questions around treatments, because there very frequently is a very small window of opportunity that patients are given to kind of have these discussions of that. I'm seeing this get better, but this is getting worse. How can we manage this? Like, I like being less sleepy, but I don't like having more migraine days. So I shouldn't have to choose which disability I'm going to suffer with. It should be, how do we actually reduce the total burden of disease, the total burden of disability, in order for me to have better days ahead? And I do think that comes with having this type of shared care decision-making, but also open communication and prioritizing the things that are important.
Excellent. I think that wraps up the questions and comments. Thank you. Oops. My provider prescribes me maximum approved doses of Adderall and Xyrem. I developed a lot of tolerance to Adderall to the point that it doesn't work alone, and I have to consume 600 milligrams of caffeine daily to stay awake for school. Xyrem helps only a little bit. My prescriber is hesitant to trial with other medications. He is a prominent sleep neurologist. Should I try to insist on trying other meds or change doctors? I also have a history of substance abuse, and other providers might reject me.
Yeah. So that is a challenge. When individuals have a history of substance abuse, they automatically do become stigmatized, and that's not the right thing, but it is the truth. And I apologize that is an additional burden for your journey. What I would state to you is having a conversation of what it is that you're having to use as compensation. So you're already having to self-medicate by using additional caffeine in place of the fact that the medications aren't optimal for you. And I think the conversation really should be directed at, these are other drugs that I know are available. Can we go over the risk benefit of changing over to these other medications? And I think if they're unable to give you specific guidance as to why you can't try all those other medications, or give very clear illustration of these are the specific risks that I'm concerned about for you specifically, then there may be value to having to see another sleep specialist just to, again, get a different opinion. I think that there needs to be ongoing reevaluation of the regimens we're on. And sometimes it's not even that the regimen stops working. It's sometimes that the circumstances also change. So again, when looking at that journey, recognizing that there's these changes over time that are occurring that maybe are not narcolepsy changes or drug changes, but other factors in your life that may be contributing to less than adequate symptom resolution. So I do think it's really important for there to be the look at what are there any other modifiable factors that will contribute to better symptom control? And then also what would be the way to be able to trial a different drug that your provider will feel safe and you will feel safe in being able to monitor safe use as well as efficacy.
Thank you, Dr. Morris. A couple of them coming in late. Thank you both for the event and discussion and the audience for participating, says Christina. And probably the last one, thank you for going through this and being a good advocate. It's such a hard thing being judged for the medications they're prescribing. Doctors are the ones that ultimately gave the diagnosis. It's not my fault that certain medications did not work. Luckily, I seem to have a good provider who has allowed me to swap through medications as necessary and has gotten me to the point of being able to live. So I appreciate people like you who allow us to get better symptom management. Thank you. Good.
Thank you.
So with that, I'd like to again thank Dr. Morris for her very inspirational presentation and for the community. She is a gift to our community. And thank you everyone for joining today.